Today we are going to talk about how our body reacts when the opioid receptors become active. All, this is Dr. Mubin Sayed. Welcome to one more session in Pain series. Today we are going to talk about what happens when the opioid receptors are activated. And what I mean by that is that, of course, once the receptors are activated, there is one effect of the opioids itself. And we discussed that last time, that what do the receptors do? Today we are going to see how our body reacts when the opioid receptors become active. So we are going to look at desensitization of receptors, tolerance, dependence, addiction, withdrawal, and then some of the diagnostic features of opioid or opioid use disorder and how those diagnoses are made. There are actually complete books around that, but I would give you some highlights of how that happens. So that is the objectives for today's discussion. I have no disclaimers. I have no conflict of interest. This is a lecture that we are producing from Dr. Bean's own platform. So let's start. Some of the references for the talk today. Number one here, US Food and Drug, information about medication-assisted treatment. So we'll talk a little more about that opioid treatment program. Today's lecture is not about the opioid treatment. Today's lecture is how our body reacts to the opioid usage. However, near the end, you would see that diagnosis and treatment is kind of touched on. So I have that reference here. Then I would be using this as well. This is American Society of Addiction Medicine. And they have a guideline which talks about opioid use disorders and then the management of those. This is that book. I have separately opened it in my PDF as well to show some parts of it. This is a huge book, so just some parts. Then this is another PDF. This is from the psychiatry.org, which discusses the difference between DSM-4 and 5, which are the diagnostic criteria for opioid dependence versus opioid addiction. And finally, this reference. So once this video is recorded and placed on Dr. Bean, the references will be present in the description of the video. So this is the Psychiatry Online, and here are all the DSM booklets like DSM-1, 2, 3, 4, and 5. Today we'll refer 4 and 5 more. Okay, so these are the references. Final and important reference is Goodman and Gilman. So this is Goodman and Gilman, and in here we are talking about effects of acute and chronic opioid receptor activation. So with these references, let's start our discussion with my drawings. So this is a quick review of what we discussed last time. So this is an opioid receptor. Remember, we have already discussed how receptor activation occurs and what kind of effects it produces. Today, we are going to talk about how does the body start responding to it. So quick review, opioid receptors are G protein coupled receptors. The receptor has on the inner side 3 proteins coupled with the receptor as second messengers. So there is an alpha protein and then beta and gamma protein. We discussed that last time as well. And then opioid receptors, major categories are the mu, which are the most abundant receptors, plus the most pharmaceutically targeted receptors. As the Gilman had written, virtually all clinically important opioid drugs target mu receptors, but we also have delta and kappa receptors too. Important thing to keep in mind over here is that when these receptors are activated, is that the calcium channels are reduced, or not reduced in number, but they're reduced in their activity, or they're blocked. When the calcium entry into the nerve terminals reduce, that causes reduced release of neurotransmitters. That is one effect. Then adenylyl cyclase is reduced. That causes reduction in cyclic GMP, which in turn causes PKA activation and further down the road effects. And we had this discussion last time that the cyclic GMP reduction or reduction in the adenylyl cyclase action is mostly considered to be responsible for long-term effects of opioid and long-term dependency-related outcomes of opioid. Then we also know that the inward rectifying potassium channels are also activated by the opioid receptor activation, which causes potassium to exit from the cell, which causes cell to become hyperpolarized. And hyperpolarized cell is difficult to activate. So it becomes difficult to activate a cell. It is stabilized, as we say, or hyperpolarized or less excitable. So that is one. Plus, it releases less neurotransmitters. So overall, whatever nerves are involved with these receptors, they become hyperpolarized, stable, and less active because they release less neurotransmitters. So this is a quick review. Now the question is, what happens to us when opioids are used? So you are going to see that the opioid usage and the body's response is in various time durations. There is an immediate response. Then there is a response that occurs within a day to weeks. And then there are responses that occur beyond weeks and months. So imagine that this is an opioid agonist. This is an opioid receptor. When the agonist is, when it binds with the receptor, and I'll ask you a question from last time, there is a pocket between two of the G protein domains which have the binding pocket for the opioid receptors. Do you remember which two proteins were these? So I hope you're saying M3 and M7. So there is a binding region between these two. Anyways, immediately, and by immediate I mean within minutes to hours, desensitization starts occurring. The desensitization means our body starts saying, you know what, there is opioid receptor activation, and I need to reduce my response to that. And so I need to reduce opioid activity. How does the body do it? This starts happening within minutes. One mechanism is the uncoupling. This is a very interesting mechanism. If I go back here to this diagram, we saw this last time that when the opioid receptor is activated, the alpha protein separates, and then beta and gamma, they separate as well. And then these proteins go within the cell cytoplasm and they act on the other enzymes to activate them to carry out their final action. When these proteins are separated, at that time, they would do their function and then they will come back and attach, or they will not come back. Another set of proteins will replace them over here, and the opioid receptor will become able to be activated once more. What will happen if these proteins are not allowed to attach back here? So that is the first one, the uncoupling. In the uncoupling, the alpha, beta, gamma, these three are separated from the receptor. Receptor becomes phosphorylated. There are phosphates that become attached to the receptor protein, the G protein. That phosphorylation causes the alpha and the beta and gamma to not be able to immediately attach back with the G protein. So if these two do not, or these three do not bind back, then this receptor will not get back into functional state right away. And this is called receptor uncoupling. Now, it is not that this would always be the case. This phosphorylation would eventually go away, and then the proteins will come back and attach here, and the receptor will become whole again and become active again. But this is our body's resistance or response to opioid receptor activation. Number one, we're talking about desensitization occurring within minutes to days. Number one is uncoupling. Number two is internalization. This is also a mechanism that is not only for opioid. Many other kind of receptors also do this, where our cell will downregulate the receptor. What does that mean? Imagine that we have a number of opioid receptors on the cell surface, and as these receptors are activated, our body would notice that we have opioid receptors activated more than normal. And what body will do, or the cells will do, is that they will sequester the receptors. They would take the receptor inside and sequester them in vesicles. This is also called downregulation. So in this context, we'll just call it internalization of opioid receptors. So when there are less receptors available on the surface, then even whatever is the amount of opioid, there will be less activation of those receptors because there are less receptors. So these are the two immediate mechanisms that occur when the opioid is administered. So if somebody says that as soon as the opioids are administered, what is, other than the opioid's own action, what is the body's or cell's response to it? You would say, well, desensitization would start occurring within minutes, and there are two mechanisms for desensitization. One is uncoupling and the other one is internalization. They both are not permanent, but that is our body's response. Then if the opioid usage is continuous, for example, let's say that there is a patient of surgery or cancer and you are giving them opioid for the pain management. And if that opioid usage is repeated or continuous over days and weeks, then what would happen is after the repeated agonist administration or continuous administration, there will be tolerance that would start developing. Now, also please remember that when we are talking about there is tolerance developing or there is desensitization, that doesn't mean that the opioids effect will go away. But the effect that was achieved with the first dose, will the intensity or that effect will not be achieved in the future with the same dose. If you want to achieve the same amount of effect, you may have to increase the dose. So reduction, tolerance, we're talking about tolerance, reduction in maximum achievable effect or right shifted dose response curve. That is the tolerance. So if you're giving the same dose over time, then the effect of the opioid would continue to reduce. This is called tolerance, and it starts happening within days to weeks. Now, the question is, how does tolerance happen? We know for desensitization, uncoupling and internalization occurs. How does tolerance happen? So there are many possible mechanisms. We are actually not clear for exactly what is the mechanism. However, the most studies have shown that the adenylyl cyclase pathway is affected for tolerance. So there is reduction in inhibition of adenylyl cyclase. What does that mean? Remember, we just discussed that in the beginning as well, that when opioids attach with the opioid receptors, they cause alpha to be separated, beta and gamma to be separated. Beta and gamma's job is to reduce the adenylyl cyclase activity, which causes reduction in cyclic AMP, which then causes a bunch of other effects as well. Now, this particular pathway, body starts resisting this pathway's downward activity. So how does the body resist this? What we do is that our cells start making more adenylyl cyclase. So this is a very important point to keep in mind, that as the opioids are suppressing the activity of adenylyl cyclase, the cells are now responding by producing more adenylyl cyclase. However, imagine that before opioid, I'm giving the just made up numbers to provide a point. Imagine before opioid usage, our cell used to have 100 adenylyl cyclase active at one time. Then came opioids and they started reducing the activity of adenylyl cyclase, and now instead of 100, only 50 are active. Our body said, you know what? I used to have 100 active at one time, and now only 50 are working. So there is something wrong. Maybe I should make more adenylyl cyclase. So it starts making more. So maybe instead of 50, now we have sufficiently more quantity of adenylyl cyclase that even when the opioid have suppressed 50 of them, we have now 60 or 70 because we made more. Why this point is important is that as you would see in withdrawals, or as you would see in abrupt stoppage of opioid, that as soon as you stop opioid abruptly, opioid suppression of adenylyl cyclase will go away because there's no more opioid. And that bulk of adenylyl cyclase that we have produced as a counter-regulation, as a resistance to opioids action, that pile of extra adenylyl cyclase will immediately start becoming active, all of them. So instead of now having 100 of them active at one time, we may have 200 of them active or 150 of them active. Again, I'm making up the numbers to create a point here, which will cause a bounce back in the symptoms. So a patient of pain who is now counter-regulating by producing more adenylyl cyclase, if that patient stops opioid abruptly, then the extra adenylyl cyclase would cause the effect that opioid was stopping. Imagine if that effect was reducing the pain intensity. When the opioid will go away and adenylyl cyclase would increase more than normal, then the patient might actually feel more pain when the opioids are stopped. So keep that in mind. This is a counter-regulatory mechanism. So in case of tolerance, if somebody says, what is the mechanism of opioid tolerance? Then you would say that this happens within days to weeks. And the mechanism is that body starts producing, as a counter-regulatory mechanism, more cyclic AMP enzymes that try to resist the suppression of cyclic AMP by opioids. This is also the reason that we might get bounce back effects. Now, that is on the cellular level. We are still on the topic of tolerance. Tolerance can be even on the organ level. For example, the brain tissue itself could decide that somehow hippocampus is not working sufficiently correctly, or somehow the lower centers are spinal cord and others are behaving differently under this new paradigm of using opioids. And the tissue might start producing resistance to it or counter regulation to it. So here, even organs like, for example, CNS can reduce their response to opioid, and that tolerance will be produced organ-wide. However, please remember that this organ-wide tolerance is not uniform throughout our body. So imagine because of opioid, a number of tissues are affected. When the tolerance starts developing, not every tissue has similar tolerance. And there are examples that can clarify that. For example, pupillary meiosis, the constriction of the pupil, which we see in, for example, people who are using opioids or heroin addicts or others, the pinpoint pupil that you see. Whatever number of days and amount of opioids are used, the pupil tissue that is responding to opioids does not become tolerant, and it would always be responding, and the meiosis would always occur. So pupillary tissue does not become tolerant. And I would discuss a little later in the talk that why does this not do it? On the other hand, emesis, so the nausea and vomiting, that is the opioid's action on GIT. Remember, opioid receptors are not only in the nervous system, for example, in the hippocampus and the basal ganglia and the spinal cord. It's not just over there, even brain stem, right? Opioid receptors are present on the immune cells. For example, macrophages have them, dendritic cells have them. Similarly, opioid receptors are present in the GIT as well. So this emesis, that is vomiting, nausea, that is an effect of opioid on the GIT. Analgesia or pain killing is an effect of opioid at the spinal cord level, and also a counter-regulation by the higher centers. But let's just use spinal cord as an example. The pain gating occurs at the spinal cord. We have discussed that in the previous lectures. Sedation is another effect that is at the central part level. These tissues that are involved with these symptoms, they start becoming tolerant and they develop mild tolerance. So that means the emesis would reduce over time as opioid is used. The sedation produced by opioids will reduce as the same dosage is used. To produce the same level of sedation, more dosage will be needed. This is tolerance we're talking about. Analgesia, the pain killing or pain gating, will reduce with the same dosage, and either the dosage would have to be increased with the frequency, or if you don't increase the dosage, analgesia will reduce. So this is the example of mild tolerance. So in this person, even when there is tolerance being developed for these tissues, the pupillary meiosis would still be present, and that would not become tolerant. That tissue will not become tolerant. And finally, euphoria produced by the opioids. So that is the opioids' action on the limbic system and the frontal cortex. The euphoria that is produced, that is rapidly tolerant tissue. So the euphoric state will be very quickly become tolerant or tolerated. And so euphoria would reduce very quickly. And for the person to continue to seek euphoria, they'll have to keep adding and increasing the dose. So that means in the same one person, pupil is not responding or becoming tolerant at all. The tissue responsible for euphoria would become immediately tolerant or very quickly, rapidly tolerant. And then there are tissues that are mildly tolerant. So the summary of this point will be that if somebody says that how does tolerance develop and is it uniform in the body? We know the mechanism of tolerance, cyclic AMP, but the tolerance is not uniform. So then, of course, and the next question will be that why is the tolerance not uniform? And I'm going to answer that a little later. And then there is the concept of cross tolerance as well. Cross tolerance is that when one kind of opioid receptor is activated or one kind of opioid agonist is given for a receptor, let's say mu receptor, then when the tolerance develops, will another agonist also have the tolerance? Will the receptors be tolerant to the other? And there is partial cross tolerance. That means that if one drug that affects on mu receptors and produces tolerance, If you change that drug, if you switch that drug with another drug that is agonist for mu receptors, that switched drug may not have the same tolerance. So the question is, why is this cross tolerance not uniform? And we do not know the answer. This is known that cross tolerance can occur. This is also known that it is not necessarily uniform, but why is it not uniform? That is not clear. The reason is very simple. I mean, why we think about it, that why is it not uniform? If you have one mu agonist and that has produced a specific tolerance, let's say after 2 weeks of usage, then another mu agonist, will that not produce the same level of tolerance? It acts on the same receptor, but somehow there is always a difference. Okay, so that is tolerance done. We have one question left in tolerance, and that is, why is there no uniform tolerance? I'm going to answer that later on. Now we are moving to next stage of opioid usage and body's counter-regulation, which then causes dependence. Now, this is a very important thing. And if you would see the DSM-4 versus DSM-5, the opioid dependence is not synonymous with opioid addiction. And in more general terms, look, opioid dependence means, imagine if there is somebody, let's say a cancer patient, who has intense pain because of the cancer. If you give them opioid, let's say they feel better. If you withdraw opioids, they will need some pain killing, right? They would need something to kill pain. They would need an analgesic. Sure, you can give them other analgesics as well, but if the pain is severe enough, they would need opioids. This is called opioid dependence. Opioid dependence is not equal to opioid addiction. Addiction is where the underlying need has gone. Maybe somebody started after a surgery on opioids, then the surgery-related pain subsided. However, they are still looking for opioid. So we'll discuss that a little more later on. So dependence is the state of adaptation manifested by withdrawal symptoms when drug is stopped. Now, dependence of opioid can be at the organ level. It can have effective outcomes. I'm not saying effective outcome, effective outcomes, which is if the effect of the opioid is, let's say, euphoria or pleasure, there could be an outcome which will be displeasure. So we'll discuss that in a second. And then it causes highly aversive behavior. Aversive behavior is if somebody has intense pains and they're using opioid, and then the opioid is stopped, their pain is still there. So of course they would like to avoid that pain and they'll say, I need opioid. In addition to this, it is possible that their body has become tolerant to opioid, they need a higher dose, etc. And then they're looking for that opioid dose to make sure that their pain is managed. So patient or the person will make robust effort to obtain more opioids. We are talking dependence. Now, let's very quickly just talk about the effective outcomes, and then we'll talk about what is the organ level behavior. So effective outcomes is that when you stop opioid and the person is in this state of dependence plus the state of adaptation to the opioid, this is bigger than tolerance, the effects will start becoming opposite to what opioids were producing. So for euphoria, dysphoria would occur, anxiety would occur, depression would occur. And it really depends upon what tissue is involved and what was the effect of opioid on that tissue and what will be the opposite of that, the counter to that. And could you tell me how this effective outcome will occur? Actually, even this part, I hope that you have in mind that cyclic AMP suppression by opioid caused the cells to make more cyclic AMP as a counter-regulation. Now, if the opioids are abruptly stopped, that extra cyclic AMP would cause a cell to do extra activity opposite to what opioids were doing by suppressing cyclic AMP. So let's see what could that be. So when opioids are stopped abruptly or stopped in a patient who had reached dependence state, and again, dependence itself is a natural dependence because there is pain that needs to be taken care of. Plus, there is an adaptation of the body as well. So when the opioids are stopped, what happens is somatomotor and autonomic outflows increase. So why do somatomotor? Somatomotor means the motor activity of the body, especially somatic body. Why would that activity increase? And why would the autonomic outflow would increase? Again, long-term effects are handled by cyclic AMP pathways. Now, what will happen to the patient? Agitation. See, this is going to be opposite to what opioids were doing. Hyperalgesia, pain will increase. So I'm just going to take pain as an example to give you further effect or explanation. So imagine that there is a nerve terminal, and this is the synaptic terminal, that is incoming nerve. Let's say this is pain nerve, and this is the second order neuron that is going further from here. Imagine this is spinal cord, dorsal horn, substantia gelatinosa, or which is the first layer, and fourth layer. This is happening somewhere over there. So normally what will happen is that the impulse would come in over here, the neurotransmitter will be released, that would go and act on the second postsynaptic nerve, and then the impulse would continue. So impulse would come in, impulse would continue. That is what would happen normally. Now imagine that this person is given opioid for pain management. What will happen is, as I said before, opioid would cause the calcium channels to reduce in their activity. So neurotransmitter release will reduce. This is the last time. So last lecture. And secondly, the inward rectifying potassium channels will open up. That would cause hyperpolarization of these nerves, which would cause it difficult for them to have action potential in them. Now, the counter-regulation is that these cells are now producing, there are cell bodies somewhere, right? So they're producing cyclic AMP, reduced cyclic AMP because of opioids. And as a counter-regulation, the cells are increasing their cyclic AMP. This is a nerve terminal. Cyclic AMP is in the nerve cell body. So I hope that that is granted. I'm just making them here for illustration. So as the cyclic AMP is increased in the cell as a counter-regulation, and then you take away opioids, then think about it. What would cyclic AMP do? It will increase the activity of this cell. Now there will be more calcium channels working. There will be more potassium channels not working. This is inward rectifying potassium channels. Plus, with every signal, there will be more neurotransmitter released, which would cause more intense, stimulation of the postsynaptic membrane, or the state will go in an excitable state. So every impulse would now be passing through this in a facilitated fashion in an excited state cell. The result is the patient would start feeling more pain. So that is the hyperalgesia. And a similar mechanism will be for others as well. So hyperalgesia would occur, more pain. Hyperthermia would occur, autonomic. Plus, remember that the temperature control centers are in the brainstem. Brainstem also have opioid receptor activity. So as soon as you take that away, the brainstem centers would also respond. So hyperthermia, hypertension, that is autonomic outflow, diarrhea, that is GIT effect, plus autonomic outflow causing more mobility. For example, pupillary dilatation. Remember, it was meiosis before, a constriction. So it is now becoming the reverse of that. Release of all pituitary and adrenal hormones. Imagine the patient's situation, that the patient who was in a dependent state, not just for their pain, but let's say their counter-regulation to opioid had brought them to this adaptation state. And then the opioid is stopped abruptly. Agitation, this patient is agitated, has more feeling of pain, has feeling of temperature, they have blood pressure increase, diarrhea, abdominal pains, pupillary dilatation, they cannot focus the eye very correctly. In addition to that, all of their hormones are releasing. Imagine the condition of this person. You can't just say to this person that, hey, this is just get over it. That's not going to happen. This person is actual physiological change state. And that state is adaptation and dependence state. So I hope that the counter-regulation is understandable, and I hope then this makes sense that cyclic AMP is the main pathway and not just the other alpha pathways, meaning potassium and calcium pathways. Then if the opioid usage continues, now let's say we're reaching the state of addiction. Addiction is when dependence is when there is a legitimate need for opioids, but their body has adapted. Addiction is that the underlying need is not there, but they still are seeking opioids. And I would actually read from the books to give you more closer and more correct definitions. But I want to show you what is the behavioral pattern. Addiction, according to the Goodman and Gilman, it is a behavioral pattern with the behavior of impulsive use of drug. Now, in case of opioid, so here is an opioid, The reason that addiction develops is that opioid cause the reward centers to be activated. Reward centers in our limbic system, when we use opioid, the reward centers become active. We feel euphoria, we feel rewarded, even when there is nothing that we achieve to get the reward. It's the opioid causing us to feel the reward. So the reward effect of opioid drives addiction. So please remember, this is a very different state. We are not talking about receptor desensitization or uncoupling or internalization. We are not talking about just the counter-regulatory mechanisms as we saw in dependence. We're not talking about cyclic AMP pathways. Now we're talking about behavioral pattern, which is a full organ, the tissue, the limbic system working together. And the limbic system is saying, well, I was feeling happy and rewarded. Opioids are not there. I'm not feeling that anymore. So that will drive the behavior, which will then be diagnosed as addiction, for example. Tolerance can develop to the opioid usage. So as the tolerance develops and the patient seeks the same rewarding feeling, they would become, and if you do a withdrawal, if you stop the opioid, then the aversive nature of the withdrawal symptoms. The withdrawal symptoms, as you saw before, agitation, hyperalgesias, palpitations, increased blood pressure, GIT movements, pituitary hormone release, adrenal hormone release, and their effects. So patient is going to, plus let's say if there's pain that is coming back, patient is going to be aversive to these symptoms. So naturally, what is the patient going to say? Patient is going to say, I need opioids. So the aversive nature of withdrawal symptoms will drive the patient for avoidance and alleviation of symptoms. Patient would want to avoid what is happening, and patient would try to alleviate it, try to fix that. For that fix, what would patient want? Patient would want opioids. In the addictive behavior, in this pattern, patient would be seeking opioids even when, in spite of physical, emotional, and societal damage to the patient, they would still look for opioids. And that is a state of addiction. Now, this is a statement from Goodman-Gilman. Dependence is not synonymous with addiction. Tolerance and dependence is seen in all patients, but is not predictive of addiction. When we start using opioid, and when a person starts using opioid for a reason, let's say pain management, the desensitization, tolerance, dependence will develop as they continue to use opioid over time. However, a patient who is using this for a reason that is present, for example, chronic pains, their dependence cannot be called addiction, and their dependence is not a predictor of addiction. This is not my statement. I am reading it directly from the book. So example, pain in cancer patient often requires prolonged treatment with opioids, but they aren't considered addicts or drug abusers. This is also from the book. I wanted to make sure that we hear what is the book writing, so that we are clear that dependence, because of the need for pain management, is dependence, not addiction. It is neither predictor of addiction, and nor by definition these patients are considered addicts or drug abusers. And I'll go more in detail in a little bit. So here, remember in the desensitization, we discussed that receptor decoupling and internalization happens. That is not the complete mechanism to explain dependence and addiction. And I hope that I have made it clear on the way that the cyclic AMP pathways in the long term and counter-regulatory mechanisms at the cell levels, that is cyclic AMP pathway, and at the tissue levels are responsible for this. So what are those counter-regulatory changes? I have already discussed this. Superactivation of adenylase cyclase after abrupt withdrawal. So what happens is we have too much adenylyl cyclase present now. And if you have an abrupt withdrawal, then that would become active, which would cause upregulation of that enzyme. The enzyme amount was already there, but now all of that is free to work, and that would cause a bounce back, and we saw the symptoms before. Then the counter-regulation is also at system level. For example, there is tolerance to mu activation by excitation of bulbospinal pathway. This is a very important mechanism to keep in mind. Bulb is our medulla oblongata in the brainstem. Brainstem or the medulla has many vital centers in it. One of the centers is respiratory center. Interestingly, from the respiratory center, fibers originate that cross over to the opposite side, then they go down to the spinal cord and they modulate the pain pathways. Yes, you're hearing it correctly. They are originating from respiratory center in the medulla, cross over to the opposite side, go down to the spinal cord and relay in the dorsal horn of the spinal cord on the pain pathway fibers. This pathway, now think about it, this is a very important thing. I want to make this little diagram here to explain it a little more. We know that we have, let's say this is a spinal cord. This is my way of drawing the spinal cord. So let's say this is a spinal cord, right? So the substantia gelatinosa, or the dorsal horn, the lamina 1, 4, and 5, what happens is the pain fibers would come in here and they will relay. Then we know that there is a relay towards the motor. Then we know that there is a relay towards the other side and the fibers would go up, right? So this is the spinothalamic tract we're talking about. But what we are seeing is that from the higher centers, from the respiratory center, fibers are emerging that are coming down here and are relaying on the dorsal horn. Now check this out. This is very interesting. As the opioids are used and the body's systems, some of them which have the receptors, they start becoming a little more stabilized, less excited. Their function goes down a little bit. Those systems are now producing counterregulation. So you already know one mechanism of cyclic AMP or increasing adrenalyl cyclase. This is the second mechanism where the higher centers, under the influence of opioid, resisting to it, are sending extra excitation signals to the spinal cord. What are they doing? The higher center is telling the spinal cord that, hey, be more excited. We know that there is something suppressing you. So we bring you the message or neurotransmitters to excite you. So body is counter-regulating to opioid, that if opioid is reducing the excitation of the tissue, body is trying to increase the excitation of the tissue. And then there will be some balance that will be formed with the given dose of opioid, that, and patient's response will be whatever that response is for that patient. But now imagine that this patient is stopped from opioid usage, right? All of a sudden, the patient's opioid usage is stopped. Then this excitatory pathway is not going to abruptly stop as well. It would still keep going. Now what is it doing? It is exciting this area of their spinal cord, which is the area related to the pain systems signaling as well. Now, when this is extra excited, because opioids are not there to create a balancing, less excitation or stabilization, then the pain fibers passing from here will work more intensely or in a more facilitated fashion, and all of a sudden patient would feel more pain. So if I go back over here, bulbospinal. So if somebody says, what are the counter-regulatory mechanisms? One answer, the cyclic AMP, adrenalyl cyclase, more enzyme production. It's a physiological response. It's not in the head of the patient. It is happening in their cells. And number two, bulbospinal pathway has become extra activated. And when the opioids are stopped, this pathway doesn't say, all right, fine, no more opioids. I'm also not going to be extra activated. No, it would stay extra activated for some days, weeks, months now. Until that time, patient is going to keep having their spinal cord excited, which would cause facilitation of signals, which would cause more feeling of pain. This is another counter-regulatory mechanism. Now the question of, moving on to another part of the topic, selective tolerance. Remember we said meiosis, the pinpoint pupil, that tissue does not become tolerant. Sedation, less tolerance. Pain, better tolerance. Euphoria, immediate rapid tolerance. So the question is, what are those mechanisms? So let's just very quickly look at this as well. This is a theory called differential tolerance. Differential tolerance means different tolerance at different tissues with the same opioid dose given to the same body. Differential tolerance and fractional occupancy requirement. This is the one I was saying that I'll discuss this later on. When we were talking about tolerance, remember I said there is a topic that why our tissues have different tolerances. This is that topic now. It is actually a very interesting mechanism. And Here, let me first say it. We actually do not know why differential tolerance occurs, just like we actually do not know how incomplete cross tolerance occurs to various drugs of the same receptor agonism. Similarly, we do not exactly know how differential tolerance occurs. But here is a theory. It's not my theory, I'm presenting it from the book. The theory is the following. Imagine that this is a tissue from eye, and this cell is responsible for meiosis. Of course, not one cell is responsible, but let's say this is that tissue. Then imagine that this is another tissue representation, and let's make it pain, analgesia. So let's say this is meiosis. Then let's say this is analgesia, pain reduction. And then let's say this is another tissue which is responsible for euphoria, right? So ciliary body, spinal cord, limbic system. The fractional occupancy requirement theory is the following. Imagine that they all have opioid receptors on them, right? Because these are the tissues we're talking about that are opioid affected tissues. Imagine, for our example, let's say they all have 100 receptors on them. When the opioid start working on these receptors, remember we talked about two things in desensitization part of the topic, that there is a decoupling of the receptor and there is an internalization of the receptor. So imagine if 10% in all tissues, we are giving sufficient quantity or dose of opioids that everywhere where there are receptors on the cell for opioid, 10% of the receptors have become internalized or decoupled, meaning they are non-functional for our opioids purpose. Now we are left with 90% active here, 90% active here, and 90% active here. Good. In the case of euphoria tissue, this 90% active is not sufficient to create the effect that 100% was creating. So even the fractional part, even a fraction of the opioid receptor, just 10%, and I'm making up that number, 10%, even just a small fraction that has gone out of function is not enough for this tissue to work fully. So 90% left are not sufficient to produce that effect of opioid. And so this tissue that was producing euphoria isn't producing euphoria with the same intensity anymore. On the other hand, let's go to analgesia. Imagine that here also 90% are left, and they are sufficient enough to keep producing pain killing or pain gating, but not with the same intensity as 100% would. And here, even if 1% are working, they produce meiosis. So 90% or 80% or 10% or even 1%, if they are active, they can produce meiosis. So here, a smaller fraction is needed to produce the effect. Here, a little larger fraction is needed to produce the effect. And here, let's say a huge fraction or almost all of them are needed to produce the effect. So as soon as the desensitization occurs, differential tolerance would develop. This is a theory, not proven mechanism. This theory is called differential tolerance and fractional occupational requirement theory. So I hope that makes sense. So I'm going to continue last part of the talk now. That is this book, the National Practice Guideline for the Treatment of Opioid Use Disorders. I want to very quickly show you this once again over here. This is American Society of Addiction Medicine, and this is their National Practice Guideline 2020. Then here, this is that book, which I have opened in a PDF as well. And here, there are some more references, including a reference where you can download all the books. Now, the National Practice Guideline for the Treatment of Opioid Use Disorder. Remember, this book is looking at it from the opioid use disorder guideline point of view. So first of all, substance use disorder. Substance use disorder is marked by a cluster of cognitive, behavioral, and physiological symptoms indicating that the individual continues to use alcohol because they're looking at the substance use, nicotine, and or other drugs despite significant related problems. And you saw that in the addiction part of the talk today, that there can be physical change or effect or damage to the patient. They can be psychological or emotional damage. There can be societal damage, that is, their standing in the society and engagement with the society might get damaged. Despite that, patient is asking or seeking drug. Diagnostic criteria are given in DSM-5. Substance use disorder is the new nomenclature of what was included as substance dependence and substance abuse in DSM-4. So this is very important. Their previous booklet, DSM-4, had substance dependence as one mechanism and substance addiction as another mechanism. In the DSM-5, they have collected that as substance use disorder. And there is a new nomenclature over there that starts from sobriety and all the way to various levels. More levels than desensitization, tolerance, dependence, addiction. This is on the page 7 of that book. Now, in the summary of recommendations, there is a section that says assessment and diagnosis of opioid use disorder, or OUD. There are a number of pages with these recommendations. We'll go deeper as we go further. I just want to give you a highlight. So if you would like, you can go and read that book as well. So for example, assessment recommendation. The first clinical priority should be given to identifying and making appropriate referral for any urgent or emergent medical or psychiatric problems, including drug-related impairment or overdose. In here, comprehensive assessment of the patient is critical for treatment planning. Then they talk about diagnosis recommendations, and the book DSM-5, related book, or the 2020 book, has minor and major changes to the previous recommendation that they show like this. For example, in the diagnosis recommendation, there is a minor revision. Other clinicians may diagnose opioid use disorder, but confirmation of diagnosis must be obtained by the prescriber before pharmacotherapy for opioid use disorder commences. What they're saying is that imagine a patient comes to you and somebody else had diagnosed them for opioid use disorder. You should not just start, being a prescriber, you should not just start prescribing the treatment. In fact, you have to get your own diagnosis. Opioid use disorder is primarily diagnosed on the basis of the history provided by the patient and a comprehensive assessment that includes a physical examination. So you can't just look at the patient and say you're an addict, or you can't just look at the patient and say you're not an addict. That's not the way to go. So you have to have a comprehensive analysis, assessment, including history plus physical examination. Similarly, there is one revision here that says drug testing is recommended during the comprehensive assessment process and during treatment to monitor patient for adherence to prescribed medication and use of alcohol or illicit and controlled substances, meaning you get their urine tested to see if they have drugs in it. The urine contains, for example, in case of opioid, even if you stop that for at least 3 days, and then when you're managing them for opioid use disorder, then you keep doing testing during that as well to make sure that patient is not taking those drugs. The frequency of testing is not yet fully developed for what should be the frequency. It would have to be what you think. Again, what I'm not talking about today is the how to diagnose and assess and manage, but I wanted to connect this, the previous discussion, to the clinical outcomes at how do clinician, as a clinician, you would look at these things. And then I want to look at page number 25, where diagnosing opioid use disorder, there is a summary of the method. So let's look at that page together. And this is the last one, and then we are good. This is the page number 25, assessment of psychological and environmental factors. And then if you see here, diagnosing opioid use disorder, here is the DSM-5 criteria for diagnosis. The diagnosis of opioid use disorder is based on criteria outlined in the DSM-5. The criteria describe a problematic pattern of opioid use leading to clinically significant impairment or distress. Why am I doing this in the mechanisms of tolerance, addictions, desensitization, and dependence? I wanted to make sure that you have a recognition of dependence being different and that patient is not addict or drug abuser versus an addict. And here is how you look at to diagnose addiction or disorder. And we'll go in details later on, but this is the part I wanted to connect together here just for a clinical perspective. The criteria describe a problematic pattern of opioid use leading to clinically significant impairment or distress. There are 11 diagnostic criteria, and severity is specified as either mild, presence of 2 to 3 symptoms out of 11, moderate, presence of 4 to 5 symptoms out of 11, or severe, presence of 6 or more symptoms out of 11 within a 12 months period. Opioid use disorder requires that at least 2 of the following 11 criteria be met within a 12 months period. So now here are these 11 criteria. Number 1, taking opioids in large amounts or over a longer period of time than intended. Larger amount or longer period. Number 2, having a persistent desire or unsuccessful attempts to reduce or control opioid use. So any 2 of them within 12 months will put the patient in that category. But as you saw over here, mild, moderate, and severe, 2 or 3 and above. Spending excess time obtaining, using, or recovering from opioids. Craving for opioids. Continuing opioid use causing inability to fulfill work, home, or school responsibilities. Remember those 3 things: physiological, emotional, and societal damage. Continuing opioid use despite having persistent social or interpersonal problems. Lack of involvement in social, occupational, or recreational activities. Using opioids in physically hazardous situation. Continuing opioid use in spite of awareness of persistent physical or psychological problems. Tolerance, including need for increased amounts of opioids or diminished effect with continued use at the same amount, as long as the patient is not taking opioids under medical supervision, which needed opioid, for example, cancer patient or patients of chronic pains. Withdrawal manifested by characteristic opioid withdrawal syndrome or taking opioids to relieve or avoid withdrawal symptoms, as long as the patient is not taking opioids under medical supervision. Now, do you see that as long as the patient is not taking opioids under medical, meaning a patient who has an actual dependence because of whatever disease they have that causes pain and they need opioid, that opioid usage is under medical supervision, and that can create withdrawal symptoms as well because it is opioid usage over time, long time. But that is not classified as addiction or drug abuse. That is why in both of those, they said as long as the patient is not taking opioid under medical supervision. Then they also have withdrawal scales. Just very quickly, when the patient is abruptly stopped, then what kind of outcome is present? And there are various scales to measure those outcomes. For example, there is the Objective Opioid Withdrawal Scale, or OOWS. There is the Subjective Opioid Withdrawal Scale, that is SOWS. There is Clinical Opioid Withdrawal Scale, or COWS. And then finally, the Clinical Institute Narcotic Assessment, or CINA. And then finally, I discussed this before as well, that testing is done too while the management is happening. This particular part I brought up because I wanted to make sure that dependence is not taken as addiction. And I hope if there is addiction, I hope that it makes sense that there is a complete protocol for how to manage that. And that protocol contains the statements to say, if not taken, as you can read, as long as the patient is not taking opioids under the medical supervision. So this is the discussion for today. I hope that it makes sense